Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Akebia Therapeutics, Inc.
Hello, I would like to welcome you to today's program, which is titled Elevating Anemia Care, New Strategies for Dialysis-Dependent Chronic Kidney Disease. My name is Wolfgang Winkelmeier. I'm a professor and the section chief of nephrology at Baylor College of Medicine in Houston, Texas. And I'm delighted to welcome our two panelists today, Dr. Jody Babbitt. Dr. Babbitt is a professor of medicine at Massachusetts General Hospital and Harvard Medical School in Boston, and Dr. Holly Kramer, who's a professor of public health sciences and medicine at Loyola University Chicago in Chicago, Illinois. Today, we'll be addressing anemia in the setting of end-stage kidney disease, and we'll start with the assessment of anemia in dialysis-dependent CKD. And then we'll talk about treatment. First of all, iron assessment, iron treatment, erythropoiesis-stimulating agents. Then we'll talk about the new kids on the block, HIF-PHI agents, and I will spell that out fully later. And then we'll talk at the end about the role of the interprofessional care team in managing dialysis-dependent CKD anemia. So, Dr. Kramer, could you take us through how and when we screen for anemia in patients with chronic kidney disease, and maybe explain why it is so important to detect and treat anemia, particularly in patients with dialysis-dependent CKD?
Thank you so much for having me here. I wanted to start with my first slide that starts with looking at how hemoglobin changes as GFR declines. So notice here that we have age greater than 65 at the top two rows and female and male, and then we're going by GFR. You can see that as we get to GFRs in less than 45, you're going to start seeing the hemoglobin decreasing to the point of where it goes from 12 to 11 to 10 as we go from stage 3 to stage 4 to stage 5. And you see that with both people who are older and with people who are younger. And just want to point out that if you look at the heat map, the KDIGO heat map for CKD classification, you can see that it's recommended to screen for anemia and iron deficiency for CKD stage 3 and higher. So don't think of just looking at the hemoglobin and ordering a complete blood count, but also order iron stores as well. So anemia of chronic kidney disease is associated with poor outcomes. So for example, it's associated with lower survival, higher risk of major adverse cardiac events, more left ventricular hypertrophy, and higher rate of hospitalizations. And then if you look at how the patients feel, they're going to report that they have lower quality of life because they have more fatigue and they might actually have difficulty in concentrating, and they're going to need more blood transfusions. So iron deficiency itself in chronic kidney disease is also associated with increased mortality and increased risk of major adverse cardiovascular events, decreased quality of life, and decreased concentration and cognition, just as we showed with the associations with anemia. But if we look at the benefits of erythropoietin-stimulating agents, we do see that it's going to raise hemoglobin levels. So this shows that when you use erythropoietin-stimulating agents versus placebo, you're going to have a much bigger increase in the hemoglobin levels. In fact, when you're using erythropoietin-stimulating agents, you're going to reduce the need for blood transfusions after about 8 weeks. And patients, when you look at using erythropoietin-stimulating agents versus placebo, that they're going to report better physical functioning, less fatigue, and just overall better physical functioning. But there are adverse outcomes that are associated with higher hemoglobin targets, so we have to be concerned about that. So the only study that had looked at this in dialysis-dependent chronic kidney disease is the U.S. normal hemoglobin and cardiac trial, which randomized people who have dialysis-dependent CKD to either a hematocrit of 42% versus a lower hematocrit of 30%. And you can see that there was about a 30% increased risk of the probability of death or myocardial infarction, although it didn't reach statistical significance. And similar studies were also showed the same findings in non-dialysis dependent CKD. Here you can see with the Choir study, and also similar in the TREAT study. And all of those two trials were in non-dialysis dependent CKD. Two studies have looked at the use of IV iron use in hemodialysis, and both of those showed that when you use more proactive iron utilization, that you're going to decrease the need for erythropoietin stimulating agents. So this shows that the primary efficacy endpoint in the pivotal trial was looking at a composite of non-fatal myocardial infarction, stroke, heart failure, hospitalization, or death. And you can see that a proactive iron regimen, where you're going to be looking at up to TSATs up to about 40%, is when you're going to be giving IV iron versus 20%, that you had a lower risk of that composite endpoint. But importantly, you had reduced need for erythropoietin stimulating agents and transfusions.
Well, thank you, Dr. Kramer. Now, when it comes to managing anemia and dialysis-dependent chronic kidney disease, there are specific steps to take. So first of all, of course, we need to rule out other causes for anemia, and especially if these causes are correctable, such as blood loss that may be overt or not, hemolysis, deficiency of folate or vitamin B12. Um, Dialysis inadequacy is an important factor to consider, as is malignancy or infection. And then we need to ask ourselves whether to replete iron. And the guidelines recommend to start thinking about repleting iron when the ferritin is less than 500 nanograms per milliliter or the TSAT is less than 30. And quite clearly in dialysis patients, the intravenous route is preferred over the oral route, especially patients who are already on dialysis. Have high difficulty to absorb iron via the oral route. And so intravenous routes certainly circumvents that problem. And then finally, we need to consider erythropoiesis stimulating agents. And, the threshold for initiation for many of us is when the hemoglobin concentration is somewhere around 9 or 9 to 10 grams per deciliters. And that may be a joint discussion with your patient. And then the target should be somewhere between 10 and 11, maybe 11.5 grams per deciliter. Now, what are the regulators of iron metabolism and of anemia in chronic kidney disease? And we used to have a time when we all were centered and focused on erythropoietin and thought, just because there's kidney failures and the kidneys don't work anymore, and they can also not produce any EPO, there is less EPO available that can, less stimulate the bone marrow. But we've learned so much since that time, and now know especially about this important factor called hepcidin. And hepcidin goes up as there's decreased kidney function, partly because of its decreased renal clearance, but also patients with advanced chronic kidney disease, and especially on dialysis, have a great degree of inflammation. And the problem with hepcidin is that it, first of all, decreases the iron uptake from gut. And that's what I just mentioned a moment ago, that oral iron does not really get absorbed in patients on dialysis, but it also decreases the mobilization of iron from iron stores. And so as a combination here, upregulated hepcidin and then also reduced erythropoietin leads to what we now know is CKD anemia, especially in patients on dialysis. And so when we have iron deficiency, we need to look, of course, specifically at ferritin. We also need to look at the TSAT. There's other more exotic parameters that are not routinely available in clinical care, such as the proportion of hypochromic red blood cells. But when altogether, we believe that iron therapy should be given. Again, when the ferritin is less than 500 and the TSAT is less than 30, then iron supplementation is indicated. So now, Dr. Babbitt, what should be done if anemia persists despite iron optimization? Is this the time when we would consider an ESA?
Yes, the new KDIGO 2026 anemia guideline recommends that in people with anemia and CKD, once correctable causes of anemia have been addressed, including iron deficiency, we suggest using an ESA rather than a HIF-PHI as first-line therapy for the treatment of anemia. And the rationale behind this is that the well documented benefits and risks of ESAs are very known over decades of use. versus the unknown longer-term benefits and risks of HIF-PHIs in the broader population of patients outside of clinical trials. Additionally, as we'll hear a little bit more about later, although HIF-PHIs are non-inferior to ESAs for anemia treatment efficacy, some studies suggest that at least some HIF-PHIs may have more major adverse cardiovascular events than ESAs, particularly in people with non-dialysis CKD. Now, there are patients in whom we might consider HIF-PHIs as first-line therapy, and particularly people who prefer an oral treatment. And they also have a role in people who have ESA hyporesponsiveness, although it's important to keep in mind that the evidence showing efficacy of HIF-PHIs in this setting at this point is still very weak. So the mechanism of action of ESAs is that these basically it's recombinant human erythropoietin, and so it boosts the circulating levels of erythropoietin to increase the erythropoietic activity in the bone marrow. And the benefits, as we heard from Dr. Kramer, is that it improves hemoglobin levels and also improves quality of life, in particular in relation to no treatment or placebo, as well as improving or reducing the need for blood transfusions. However, ESAs do have potential risks, and again, this was largely seen in studies that randomized patients to try to receive ESAs to try to normalize their hemoglobin levels. And the risks that were seen when, compared to relatively lower hemoglobin levels, closer to 10 to 11 that we now target, the risks include major adverse cardiovascular events, thromboembolic events, vascular access thrombosis, hypertension, and malignancy. Now, there are several different types of ESAs that we use in clinical practice, and they all have pretty much similar efficacy. The major difference really is in the half-life, which then affects the dosing interval. So we have epitin alpha, which is the originator drugs, and these are dosed basically 3 times per week, usually about 50 to 100 units per kg as a starting dose. We also have darbepoetin alpha, which is hyperglycosylated, so it has extra sugar groups on it that help to increase the half-life, and therefore we can now dose weekly or every 2 weeks. And finally, we have the methoxy polyethylene glycol, epitin beta, which has that extra group on it, which then increases the half-life even further so that these drugs can be administered every 2 weeks or even once a month. And you can see on the slide the sort of starting doses that are recommended. So ESAs are dosed intravenously or subcutaneously according to the patient weight, and we can really choose the route based on patient preferences, local practices, and costs. For epitin alpha, the lower doses can actually be used subcutaneously versus intravenously, although that's not the case for darbepoetin. But of course, IV administration is easier and so may be preferred by many people and providers. Now, not everybody responds to ESAs, and there are what we call ESA hyporesponsiveness in patients with anemia of CKD. And there are many definitions that have been proposed. Some of the more common ones are if you're needing more than 450 units per kg per week of intravenous epitin, or 300 international units per kg per week subcutaneously, or a darbepoetin a dose of more than 1.5 micrograms per kilogram per week. The KDIGO 2012 guidelines had a different definition, basically saying that if there's no increase in hemoglobin from the baseline after the first month on the appropriate weight-based dose of ESAs, this is considered hyporesponsiveness. Or you could have subsequent hyporesponsiveness if people were on stable doses, but then require 2 increases in doses up to 50% beyond the dose where they had previously been stable. The mechanisms of ESA hyperresponsiveness are multifactorial. We have blood-related causes, including iron deficiency, inflammation, blood loss, and underlying hematologic disorders like hemoglobinopathies or multiple myeloma. And additional causes include hyperparathyroidism, inadequate dialysis, malignancy, nutritional deficiencies such as copper, zinc, folic acid, vitamin B12, carnitine, or vitamin E, and medications, including RAS inhibition. And actually, in about 30% of patients, the cause is unknown. But it's an important problem because we know that poor responders to ESAs actually have worse outcomes. They have a higher risk of morbidity and mortality. And there's probably two reasons for this. One is that you tend to need higher doses of ESAs, which again, the studies suggest may be associated with these adverse outcomes. And there's also probably patient characteristics about these poor responders that confers this increased risk. So, Dr. Ruckelmeyer, what are other options for anemia in patients with dialysis-dependent CKD?
So now we are talking about HIF-PHIs, or let me pronounce it, hypoxia-inducible factor prolyl hydroxylase inhibitors. And so let me give you a brief introduction into hypoxia-inducible factors. It's an ancient biological system that is present in all mammalian cells. It's present in mammalians, it's present in fish, it's even present in invertebrates, and altogether is supposed to help organisms survive in the presence of acute or chronic hypoxia. And so HIF, hypoxia-inducible factor alpha, is being synthesized in almost all cells on an ongoing basis. However, then very, very quickly, through the mediation of prolyl hydroxylases being degraded, and it's a really strange thing that the body uses so much energy to build something just to destroy it immediately, and that's of course in the presence of adequate oxygen environment. However, if you were now in a situation where ambient oxygen was low, a situation of hypoxia, then the prolyl hydroxylase is actually being blocked. And so the hypoxia-inducible factor alpha or HIF alpha can then be translocated into the nucleus where it can pair up with HIF beta and then together lead to an entire array of gene transcriptions that have an entire myriad of downstream effects. And that those effects include increased erythropoiesis, better energy metabolism, endothelial health and vascular repair, responses to oxidative stress, and also renal protective factors. And so HIF-PHI is a Nobel Prize winning paradigm that was only very recently discovered that is now being utilized in these new drugs, the HIF-PHIs. And those drugs mimic this hypoxia essentially. Now, if you have hypoxia-inducible factor present, it leads to increased expression and production of erythropoietin. And this may be in the kidney, it may be in the liver. It even happens in patients who have no kidneys, so whose kidneys have been removed. It's quite remarkable. And so when you then juxtapose, external administration of therapeutic erythropoietin and look at what happens after administration of a HIF-PHI, for example, roxadustat, you can see that after just a few hours, the curves, the exposure curves, if you will, concentration curves of erythropoietin almost overlap. But the HIF-PHI avoids this maximum level and concentration that happens immediately following the intravenous administration. And so there are currently two drugs that are approved in the United States. The third one, roxadustat, tried to make it to market but didn't. And then we also have daprodustat, which was introduced in the market but then a year later withdrawn by the sponsor. And so now we have one on the market currently, and that is vadadustat. And vadadustat came to the market for the use in patients who are dialysis dependent and who have been on dialysis for at least 3 months. And the program that brought this drug to market was the INNOVATE program. And it consisted of two sub-trials, if you will. A smaller trial in just under 400 patients where these patients were incident patients on dialysis. They had to have been on dialysis no more than 16 weeks. And they were previously ESA naive. And as you can see here, the comparison between vadadustat and darbepoetin alpha, both drugs led over time to an increase in hemoglobin concentration, and the primary evaluation period was 36 to 54 weeks. And as you can see here, during that time, these two concentrations of hemoglobin between the two drugs were nearly superimposed, and the mean difference was negative 0.31 grams per deciliter. The 95% confidence limit, the lower limit was negative 0.53. This was a non-inferiority design. And so it had to be above negative 0.75, and negative 0.53 satisfies that. So that was in non-inferior. And the same can be observed on the right-hand side, where you have the prevalent dialysis-dependent CKD trial of patients who are not ESA naive. And you can see again that over time, the hemoglobin concentrations evolved in a very similar way. And again, in the primary evaluation window, the mean depth difference was negative 0.17 grams per deciliter. That's hemoglobin concentration, and that is far away in the 95% confidence limit from negative 0.75. So again, non-inferiority was demonstrated here. There was also a sub-study done where the patients from this trial were extracted who were on peritoneal dialysis. And of course, the sample size was less. There were 309 patients on receiving peritoneal dialysis, again, that were randomly assigned to either vadadustat or darbepoetin alpha. And the treatment difference, as you can see here, was again very, very minimal. It was negative 0.1. The lower limit of the 95% confidence limit was negative 0.33. You could call this non-inferior, although this is a post-hoc testing and cannot be really, communicated as such. And then also time to first MACE, where vadadustat was found to be non-inferior to darbepoetin alpha. That's also the case in patients with peritoneal dialysis. The hazard ratio here was 1.1, although the confidence limit was rather wide because of the smaller sample size. Here we have the cardiovascular risk that I just alluded to. On the left-hand side, the ASCEND-D study. That's for daprodustat, which is no longer on the market in the United States. On the right-hand side, you have the INNOVATE trial for vadadustat. In both cases, the non-inferiority limit or threshold was 1.25 for the hazard ratio for MACE. And again, on the left-hand side, you see that the upper limit was 1.07. Far away, it didn't cross the non-inferiority threshold. And the same thing on the right-hand side for vadadustat, where the upper limit of the 95% confidence limit was 1.11. Again, didn't even touch 1.25. So non-inferior compared to the erythropoiesis-stimulating agent. In the case of vadadustat, it was darbepoetin alpha, was established. Now, safety data. So the cardiovascular outcomes, I just told you that HIF-PHIs have met the non-inferiority criteria for MACE in cardiovascular outcome trials in patients with dialysis-dependent CKD anemia. Here, it's important to note that similar trials also were conducted in patients not yet on dialysis with advanced CKD. And unfortunately, those trials did not satisfy non-inferiority and therefore didn't come to market with that specific indication. So again, vadadustat is the only HIF-PHI currently available, and it's only available and labeled for the use in patients on dialysis who had been on dialysis for at least 3 months. There's also higher risk for thromboembolic events compared to ESAs or placebo, which has been noted for some of the HIF-PHIs. And the mechanisms for this are really complex and poorly understood. But in terms of prescribing information, vadadustat has a boxed warning, which everybody knows quite well from looking at the labels for any of the ESAs. And the boxed warning specifically is for an increased risk of death, myocardial infarction, stroke, venous thromboembolism, and thrombosis of vascular access. And again, we know these boxed warning from ESAs, and they kind of got carried forward because that was the comparison group against which vadadustat was tested in these trials. Dr. Kramer, even with ESAs and HIF-PHIs, we need to be able to work as an interprofessional team to effectively utilize these agents and manage our patients efficiently. Can you tell us about how your team collaborates in your practice and some things that work particularly well?
I think interprofessional teams are incredibly important, not just within a dialysis unit, but then outside the dialysis unit as well. So within a dialysis unit, anemia is often going to be managed by a care team, including nurse practitioners and the primary nephrologist. But also, there should be a pharmacist is great to be involved as well because, as Dr. Babbitt has said before, medications can often complicate anemia management. So it's important to really have an understanding of how all these drugs could be interacting with each other. And then also outside the dialysis unit, it's important to communicate with cardiologists and with gastroenterologists and all of the other specialists that could be working with the patient to make sure that everyone is aware of any kind of complications with anticoagulants that could be prescribed for the patient. And then also their iron stores are being managed and all of those other nutritional deficiencies are also being addressed. So I think because of the fact that there's so many details that are needed to be monitored in the setting of anemia in patients who are dialysis dependent, it's really important that we have a team approach. So, the benefits of interprofessional teams include repeated management of patients with dialysis dependent CKD anemia allows other clinicians to develop familiarity with the guidelines and also develop that nuanced expertise to really focus on all of these details. And it also can improve the relationships between specialists and nurse practitioners or physician's assistants and increase communication outside of formal team meetings, allowing for quicker referrals, fewer delays in care, and improve interprofessional trust, and overall improve quality of care delivered for patients.
Excellent. Thank you so much, Dr. Kramer. So, as we're wrapping up this program, I would like to invite our panelists to give me just a very quick key takeaway from this program. What does our audience need to take from this last half hour that they listened to?
So, my key takeaways are number one, you should start thinking about screening for anemia in stage CKD stage 3 all the way through advanced CKD. But don't think of just checking a complete blood count, also assess iron stores. So, you want to not just check a CBC, but also iron stores.
Dr. Babbitt.
Well, I think this is an exciting to have new tools in the toolbox that we can use to treat anemia. But it's very important for us to be educated about the benefits and risks of each particular agent, and so that we can individualize care as appropriate for each of our patients.
I completely agree with your points. And as somebody who actually exclusively sees dialysis patients in the hospital setting, the collaborative approach really transcends into that setting as well. And it's important to be aware of all these new developments as patients come in and no longer just on your epoetin, but maybe on an oral drug nowadays, and how to appropriately communicate that to your colleagues inside the hospitals and manage the patient well during their stay. So at this point, I would like to thank our panelists very much. Thank you, Dr. Babbitt, and thank you, Dr. Kramer, for participating. And I also would like to thank our audience for being with us for the last 30 minutes. And I hope that this was informative for everybody. Please continue on to answer the questions that follow and also complete the evaluation. Have a great day.